Good afternoon, everybody. We're just going to start our third session in this mini lecture series, and I'm delighted to welcome our first speaker today, who is James Moore. James is one of the founders of Marylebone Health Group, and he currently works in New York as the Return to Performance Coordinator for the Brooklyn Nets. This is an NBA professional basketball team where he supports the directors of performance and sports medicine by aligning the processes for player availability, injury risk education, performance metrics, and effective return from injury. Prior to this, James was performance director for Andy Murray Tennis, a professional tennis player who they worked closely with, getting him back to competitive tennis. He's obviously a former world #1. We all know Andy Murray's history. And he did very well getting back to professional tennis after what he's been through. One of the highlights of James's career is leading healthcare delegation for Team GB at the Rio Olympics in 2016. And he's currently not happy with all of this. He's enrolled as a PhD candidate at University College of London to further develop his research and his education, and the Trobe University, Melbourne, where he's working to model hip joint and assess muscle function in healthy and injured subjects. And so today's topic is on the Achilles tendon, on Achilles tendinopathy in particular. And James, we're delighted to have you with us here all the way from New York. And I'll be very happy if you want to share your screen, and we'll listen to your presentation. All the very best.
Thank you, Patrick. Thank you for such a flattering introduction, and welcome everybody else. Hopefully this will be informative. Guys, so look, we're going to look at conservative management of an acute Achilles tendon tear. I've been asked to present this in about 15 minutes. It might be a fraction longer, so I might just whip through it in some sort of manner. And if there's any questions, we can come back into it afterwards in that instance. So to set the scene, this is the injury. And what we've looked at is a case study within an international and English Premier League footballer, and how we conservatively managed something that was borderline surgical at the time. So the guy you're going to see is that guy just coming into picture there on that green box. And you'll see the club spontaneously ruptured under that high tensile load. All right. This is the MRI of his rupture, so it's quite a high rupture. It's over 10 centimeters above the insertion into the Achilles, where normally you would see like a mid-substance tendinopathy being a lot lower. It's a grade 3C soleus aponeurotic posterior aponeurosis tear into the Achilles tendon, and you can see the disruption there. And certainly to look at that, that would look like it's borderline surgery, but there's tension and continuity within the tissue, so it was deemed something that we could look at rehabilitating conservatively. So that's the mechanism. If we go back a little bit into the functional anatomy, and just to review that the Achilles tendon is a helix, it's a spiral structure. It's got different fibers coming from lateral, medial, gastroc, soleus, all entwining, and there is a different anatomical relationship depending on the individual that you are dealing with, and depending on their genetic profile and sporting profile as how the muscles developed. We know that when you start to put the Achilles under stretch and under load, and that could be the tension as in passive stretch, elongation as in increased dorsiflexion range, or load as in higher muscle contraction, which will lengthen the tendon, that it narrows in the middle. And you see this change in the tendon nature in terms of its overall sort of cross-sectional shape as it undergoes high tensile forces. And that's one of the things that may well lead to degeneration of the collagen over periods of time. What we also know is that when you move from a supination to a pronation point of view, there's a torsion that occurs within the tendon. The tendon is a helix, and when you torsion a helix, much like if you were wringing out a wet tea towel, you get strain on the collagen, which can lead to a level of poor vascularization, which can lead to degeneration within the collagen. What we see here anatomically, again, is just a bit more of a split up of the different fibers and the way in which they insert, and we can see that insertion into the Achilles itself, or into the calcaneum itself. And we see the fact that soleus makes up the majority of the medial aspect of the Achilles tendon. And so when we get to looking at the paper later, the paper talks a lot more about mid-substance tendinopathy, And again, that may well be related, particularly on the medial side, to number 4 there in that bottom Sarzo picture, where soleus has a larger proportion. And what we see in the top left is the different sort of distribution of soleus to gastroc anatomically across different population groups. What we also know, though, is that as it inserts into the calcaneum, you get different torsion and different forces that are generated. And so we can see the forces that have been depicted by the Bilal paper, with the medial fibers of gastroc going more laterally, the lateral fibers coming more anteriorly, soleus going more medial and anteriorly. And so we see this force vector profile from soleus to produce plantar flexion, but soleus also has a supination or an inversion moment at the calcaneum. Lateral facet of gastroc will have an eversion moment. Medial head of gastroc will have an inversion moment as well. So there's different ways in which you can influence different muscle structures depending on the position of the foot as well in terms of loading the Achilles. We also know that the muscle contour can be really important, and the cross-sectional area of soleus in the green versus lateral gastroc in blue and medial gastroc in the red is critical. And we see this cross-sectional area being taken there. And you can look at that in relationship to both the tibia and the fibula. And we would certainly argue in an elite sport world that that cross-sectional area of soleus is important towards stabilizing the tib-fib joint, whether that's the superior or inferior. So may well have an association to knee problems and certainly to syndesmotic injuries. And what we see with soleus is that when you look at it on a muscle taper point of view, and just to orientate you, on the left is basic cross-section area, which has a correlation towards force or the stress rate. So how much load can you put on the Achilles tendon? And on the, so that's on the vertical axis. And on the horizontal axis, you have excursion, so fiber length, which influences range of movement. And what we clearly see here is that soleus is by far the strongest muscle in the lower limb, but it's not particularly great at moving you. Medial and lateral gastroc still are not amazing at moving you, but again, they produce relatively lower increments of force, with medial being significantly stronger than lateral. All right, and then what we see at the bottom in the yellow and the brown is the deep medial compartment. So tib post is a very strong muscle, but doesn't move you very much, whereas things like flexor hallucis longus influence movement a lot more, along with extensor hallucis longus. So, and we also know that soleus is a slow oxidative glycolytic muscle, so it never gets tired. So quite often we talk about it as a Greek god of muscle. It is able to do everything that you need it to do: force, cross-sectional area for stability and shock absorption, and it doesn't get tired. If we look at sporting or normal movements into sporting movements, we see that the calf is important just for standing balance. And this is the Carruthers paper in 2016, where you can see that for an 80-kilo individual, just to stand on the spot requires about 25 kilograms of force into plantar flexion across all of the plantar flexor muscle group. So even just standing balance is important for good Achilles and calf function. We see that with a sit to stand, that soleus generates 50 kilograms, medial gastroc generates 50 kilograms. So we might be talking, oh, well, sporting movement, where do I need to get you back to? But even just everyday movement, you're producing 100 kilograms worth of force to sit to stand into plantar flexion, to push into the ground, to allow your extensor muscle group in your knees and your hips, which are obviously driving the movement, to have a stable base in order to drive that movement. So understanding those forces is important when you're looking at a rehab model back to sport. And again, we can see with ascending and descending stairs, everyone might talk about, oh, well, glute med and hip control. But the dominant thing that is controlling the movement on ascending and descending is your soleus, with a large contribution of your vasti, all right, and glute med, obviously, but soleus is really dominating the movement parameter. So we need to make sure that we've got, if we're going to rehab somebody, we've got effective muscle function within the triceps suri, but in particular with soleus. And this is just a slide that compares walking at, so on the left-hand group of 3 slide graphs, you've got PW at the top, which is preferred walking. On the right-hand 3, we've got PR, which is preferred running. So rather than setting a set speed, you're comparing and contrasting what people are comfortable at doing. So we see in preferred walking, glute med is dominant within supporting the hip joint, and same thing with rim running, and the quadriceps are doing a large amount of work. But the gastroc roll at the knee is changing its function from that heel lift to toe off phase when you're walking, but much more around vertical force and mid stance phase when you're running. Same thing when we get to the ankle, is that at the ankle, soleus is now dominating the heel lift to toe off phase more than gastroc is. But when we're then looking at mid stance, that foot flat to mid stance phase in running, that's when soleus is dominating over gastroc. Okay, so understanding the change in the demand of the muscle and where it needs to be strong in the range of the ankle joint and or knee joint is important when you're looking at rehabilitation. When we look at running, I'm going to go over this very quickly. In short, we've got 12 kilometers an hour, 18, 24, 32. I'm not too concerned about going after the fast speed. The long and short of this is at 12 and 18 kilometers an hour, the dominant force in order to get you back running, if we're looking at any sort of weekend warrior or somebody 12 kilometers an hour, about 3 meters per second speed, is all about your triceps serratus, so your gastrosoleus function. And what we also see here on this force length curve is once you get really fast, you don't have enough time to be strong. So that's all about elasticity and how springy you are. But as you run slowly, so 3.5 meters a second, so 12 kilometers an hour kind of speed, that's about 8 miles an hour kind of running speed. You're looking at the gastroc and the soleus working much harder on that eccentric phase. And that's where the eccentric phase becomes very important within some of the strength parameters. You're looking at change of direction, then we can see from a change of direction point of view from this Marshall paper, that again, it's all about your ankle foot complex. So you may be drawn to the hip here and think, oh, the hip's working hard, the quad's working hard, but it is all about that plantar flexion moment. And again, we can see, just as an overview, the top end for sport is that Achilles tendon may well be taken up to 12.5 times body weight, or 9,000 newtons, 9 kilonewtons worth of force, depending whether you're heel striking or full foot running. And the heel strike would be less, it would be around 7,000 newtons, whereas when you're on the ball of the foot, you're around 9,000 newtons. So if we're going to rehab, we need to understand strength diagnostics. We can look at a CT calf raise test, which is really valid. And Mike Lancaster is over in at Northampton Saints now, has recently published this. 355 subjects, roughly 105 kilograms worth of weight, and the 1.86 times body weight CT calf ISO was a good score. Now I'd say, okay, that's great, but for me, that's an early to intermediate stage rehabilitation testing parameter, and you'll understand why in a second. We can look at a number of different sort of parameters. And if we look at some of the work that's been done over by Sportsmith, then again, we're talking greater than 3 newtons per kilogram in terms of the gold standard. And so that would be a lot higher than the 2 times body weight that's seen on that previous paper by Mike Lancaster. What we did, because we were more interested in standing, which is more of an end stage return to sport, we collected over 300 data sets within the Olympic world of both male and female athletes. We didn't publish this for obvious reasons, because if we do, then the Irish get to find out about it and they come and beat us at the Olympics, which is just not, the way we want things to happen. Tongue in cheek a little bit there. And if we look in here, our lowest force was in synchronized swimming at 1.6 times body weight. Our highest was at 5 times body weight. We had 30 sets at over 4 times body weight, so 10%. And a lot of them were women's rugby players. And that's critical for change of direction, which is obviously a very big part of any sort of contact sport in terms of what you're dealing with. And certainly what we found within that ankle foot complex as well was this is our data sets within the men's GB7s team going to Rio 2016, and 23 of our 26 data sets were over 3.5 times body weight. So if we're comparing that to Mike Lancaster's work at 2 times body weight, this is a significantly better marker, and our best athletes were over 5 times body weight, over 4.5, 5 times body weight. So you want to get a lot more force. You're not going to be able to measure that on the seated calf raise test. You need to measure that on the standing calf raise test. So in short, in order to get back to running, you need to be able to produce plantar flexion, and that needs to be developed or in proportion to your knee extension. Now, this is a very famous footballer that was at a great club in North London in red and then moved to this rather dodgy club in East London in purple. But he had a lot of recurrent ankle, Achilles related issues. And the long and short of it is here, all I want you to understand is if you look at his right hand side, which is the problematic side, he was at 72% calf to quad ratio, whereas on the left, he was at 90%. And that's a more optimal. So it's that calf to quad ratio is critical for return to running. I'm going to whip over this in a nutshell. All we're really trying to say is if you're going to return somebody back to sport, you want to make sure the single joint is efficient. So the ankle joint is efficient into plantar flexion, dorsiflexion, whatever that looks like, that you can load transfer. So the forefoot can transfer to the hind foot, which can transfer to the knee effectively. And then you've got system efficiency. So the whole kinetic chain, whether that be from the shoulder down or from the hip or trunk down, is working effectively. Our loading cycles we look at are high neural demand with low load, high reps based on Henneman's principle, then going to max force, then max tension, then speed, and all the time building endurance and proprioception in the background. All right, and that's our principle by how we look at our loading cycles. So if I give you some examples now in the last couple of minutes as to what we would do, first thing we would really go after is that kind of high force. And so we might look at things like an isometric calf raise that's done here. And this gentleman just needs to bend his knee a little bit more so that he's getting a bit more load on the triceps surae to get the load onto the Achilles tendon. From an elite sport point of view, we might be looking at 3 times body weight. General population, we may just be looking at body weight because it's proportional to their demands of what they're trying to get back to doing. And you can clearly see there the good recruitment of gastroc soleus as he's maintaining that isometric force and balancing that with the quadricep. We then might look at something where you're looking at more of a quick foot change. And I just wanted you to hear the force that's being applied to the leg press. Now that will have a bit more of a flexor lucis longus bias in terms of what we're looking to do. We may then move as a force point of view towards things like a plie calf raise. Now the reason why we go into a turnout here is if you externally rotate the ankle, you tend to lock out the subtalar joint, which increases the capacity for the triceps surae to generate that force. And you can clearly see here the right leg is atrophied relative to the left, all right? And that's a critical thing we're trying to influence. You could add in an abduction band, so therefore you're creating an adduction moment, which will bias the medial musculature, or you can take them through a larger range of movement by going down over the edge of a step from a plie so they can start to control that pronation moment and come back out of it supination wise, again to counteract that avascular mechanism in the helix of the Achilles tendon. So just think ballerinas, first position, massive calves. There's a reason why that happens. A lot of that's based on mechanics. Soleus wise, we will start with things like a sumo calf raise, and just at body weight is a critical way to improve that first and foremost. Then go to single leg calf, and you see Michael there just tapping his chest. You need to make sure your weight is forward so that you're increasing the dorsiflexion moment arm, which will then increase the recruitment fibers of soleus. If you're not forward, it becomes more of a hip flexor drill. And then you want something where the load is away from the lever arm of the ankle joint and in front of it, which then increases the relative demand because triceps surae is a second class lever, and therefore you want more force away from the axis of movement. And if the weight is on top of the knee, it is over the axis of movement, and therefore you won't get the same development. We'll move to tension work. So we might look at stuff where we're going single leg calf whilst maintaining your balance and trying to get some dissociation from plantar flexion to neutral, and then adding in things like bands around the big toe to increase the FHL recruitment and get the dissociation between overusing FHL versus the triceps surae. Changing the lever arm by going into what's called a donkey calf raise. So you're getting much more lever and load that's anterior to the axis to then get more load on that triceps surae and get more tension, and equally supporting the ankle joint by making sure that tibialis anterior is well developed as well. And certainly by lowering kettlebells over the edge of a step can be a great way to control pronation moment, which again will control the avascular mechanism. Then we move into the more specific stuff we did with Calvin here, with Callum here. So this is
Good, step on the toe,
stepping
good.
forwards. And if I good. So if you can see, if I pause that, you can see there with Callum, he has a tendency to go into lateral foot roll off, overuse his peronei as his plantar flexion moment and not really drive through the forefoot. And so what we're doing is more functional load and trying to generate more stiffness into plantar flexion versus more dorsiflexion range of motion control to try and make that more functional, where he's sliding the heel to in front of the big toe as he moves, again, just as a recovery strategy in between. Then we'll move to sort of high speed efforts where we might be looking at rapid calf raises on a leg press. And again, 2 to 3 times body weight load. In the elite level, maybe body weight load in the sub-elite level, to then maybe rebound work on the leg press to then get some reactivity and some more elastic stiffness, and then move to sort of muscle control work here. So the purpose here is to pull up with the hamstring and to place the foot down with
good, that's a nice one.
Heel dropping.
Good.
So again, just looking at body weight control drills. Now this is then progression of that into soleus control in a bridge. So on the ball of the foot, bent knee tucked underneath you, controlling hip to knee to ankle, so that kinetic chain system. Moving that to a flat foot quick bridge change, where there's still going to be a plantar flexion moment, but less on the ball of the foot, to then moving that to a ball foot quick change. And as you can see, Callum's having to get that control and set the drill up effectively. And the speed is not as good as when it is flat foot, but then that's something to build upon. And as he progresses his neuromuscular control, it gets better. Finally, it's about integrating back into running. And we can do that through a series of different drills, whether that's, if this can work, there we go, just always conscious. All right, it went a bit too quick. That was my fault. I pressed the buttons too fast. That happens with Teams a bit. So this is a flat foot lateral skip. The first one was a forward skip, backward skip, which is fairly straightforward, into things like, this works, a carioca or grapevine, into aspects like side skips with twist forwards and then twist backwards on the way back. So you're always working that neuromuscular control, but you can work over 20 meters, 5 different drills, 20 meters times 2, 100 meters worth of work, and then sort of zigzag skipping, which should be occurring here, to then get that kind of change of direction moment around the ankle as well, and that neuromuscular control. Building the volume up on those sort of activities is useful. Looking at things like backwards running and building up a capacity, and we look at 300 meters worth of backwards running done over 30 meter stretches as a shuttle run, and that can be really good for tensile load. And then extra things like uphill running or rhythm-based running are for 500 to 2Ks worth of distance, is a nice way to get that continuous elastic load onto the tendon and build that sort of collagen matrix around what you're trying to do. All right, and it's just more sustained rhythm. We prefer that on a treadmill because you can set the speed and it doesn't fluctuate like it might do outdoors. And we know that works from this work by Okadara that basically showed that if you run uphill, you increase the muscular effort, but you reduce the joint angle and the joint load. So just to finally finish off, I put this in there. This is like one of Franz Bosch's models of progressive calf load, which I believe this has been recorded, so you can look at that in due course, and I'm running over time, so I'm going to skip over that for now, but it's a progressive return to run model from rehab to running conditioning after you've done all the exercise selection we gave you. And so finally, one of the downsides of working in elite sport is that you might support a team like Arsenal, and then you get a player back for Newcastle who comes back, and in the first game back, he puts Arsenal out of the Champions League contention here. And if you watch him, like his speed at this point, some of the data that came back from the Premier League was that his running mechanics had improved after the rehabilitation from his Achilles injury. First game back influences the goal that puts Arsenal out of the Champions League. So there we go. So the downside of working in professional sport, sometimes you inhibit your own team. Hopefully that was useful. Bit of a whirlwind tour. Apologies for running over. There's my handles if you want to contact me. I'll hand over to the other guys now.
That's great, James. Thanks very much. What we'll do is we'll move straight on to Johnny. So we're behind time, and then we'll try and come back for questions at the end, if that's okay. And feel free, everybody, to put any questions through the Q&A in the chat in the meantime, and we can maybe answer those then once we've discussion at the end. So we'll move on to Mr. Johnny McKenna. Johnny is an accomplished foot and ankle surgeon. He's a consultant orthopedic surgeon. He's based in the Sports Surgery Clinic in Dublin. And he's a wealth of knowledge and expertise in managing athletes with a foot and ankle problems. And he's going to speak to us today on managing Achilles tendinopathy and getting the best outcome in return to sports for the athletes. Johnny, you're very welcome, and we'll let you take off.
So I want to talk about the surgical side of this, and I left the surgical word out of it. As far as I'm concerned, management of an Achilles tendon rupture is surgical. I fix almost all of these. There's never an always, but it would be extremely unusual that I wouldn't fix an Achilles tendon rupture, irrespective of age or activity level. And it is controversial in loads of places where they say, no, we don't fix them, we don't do this, we don't do that. But I've a reasonably good reason in my own head for fixing them. So this is Achilles, and Achilles was a famous Greek warrior. He was actually born essentially a normal person. He was one of 6 children. The other 5 died. That made him think he was special or stronger than the others. And his mother thought he was special, so she was a sea nymph, and she dipped him in the river Styx, and she held him by the heel and dipped him underneath, and that was to make him impervious to injury. And his dad also wanted him to be a warrior. He was a famous king, and he sent him off to this guy Charon to teach him how to become a famous warrior. And he subsequently went and he fought in the Trojan Wars, and he famously killed Hector in the Battle of Troy, only to be caught by a stray arrow by Paris, who was Hector's brother, hit him in the heel, and he died. So that was the story of Achilles, but it kind of brings us to where we are. This is an Achilles tendon on the right hand side, and you see it's an equally big, strong. It's a fabulous structure. It pushes multiples of body weight, does it thousands of times every day, and its only real difficulty is it's a little bit like Achilles himself. It has this area of weakness, and it occasionally just fails, and when it fails catastrophically. I mean, if you look again, if you go back and look at this is a big, solid, thick black structure on the back of the tendon. On the right hand side, this is a complete and utter implosion, and it's very different to the picture on the left, which shows a small little transverse tear. That's not the way an Achilles tendon tears. It explodes. The whole thing goes bang. There's a big, massive release of energy, and what people feel is directly proportional to the amount of energy released, which is directly proportional to the strength of the structure that snaps. So when they say, I felt a massive whack and I looked around to see who kicked me, that's because there was a massive amount of energy released. And the zone of injury is the entire length of that picture on the left. It isn't just a simple transverse thing. It blows apart. So the biggest thing with all of these is don't miss the diagnosis, right? The picture down on the bottom left is a Sumatran rhino, right? Now, they thought that these things were extinct up until a few years ago when they found about 6 of them wandering around the middle of a jungle. They're phenomenally rare. No one is ever going to see one. But I've put it beside a picture of a partial Achilles tendon rupture only because it is equally rare. If anyone ever tells you they have a partial rupture on ultrasound, that is complete and utter rubbish until someone can prove it to be partial. I've seen one, that's it. It's in a photograph. I haven't seen any other since, and I'm not expecting to see another one. So 25% of these are missed. Most of them are on the basis of a really bad ultrasound report or this complete and utter inability to listen to the patient. And when they say, I was playing sport, I felt a bang, I looked around to see who kicked me, there was no one there. He's put his hand up and said, my Achilles is ruptured, and nothing else should convince you otherwise. Okay, so it's very controversial. Loads of places treat these conservatively. I'm I don't. I think if you're going to treat it conservatively, you have very, very fixed guidelines. It has to be within 24 or 48 hours. The gap has to close. You have to have a plan. And the difficulty with treating this conservatively is the lack of a plan or a proper plan. So this is Spider-Man No Way Home, and MJ, Spider-Man's girlfriend, came up with a fabulous line in the middle of it. If you expect disappointment, then you'll never really get disappointed. So that's my notion of conservative management of Achilles tendon. You know, the word in Ireland is, you'll be grand. Of course you'll be grand. You won't be great. You won't be fabulous. You won't be brilliant. You will only ever just be grand. And that's just not good enough. If you look at power outputs with conservative management, they're really coming up at 70, maybe 75%, but that's an absolute tops. And they've no way of getting beyond that. That's their top level. See, what I love about sports is there, and if you look at James's videos, everybody there is looking for 100%. And it's the only thing that you should accept as an outcome. You have to chase an end goal where everyone is going to get back doing everything they want to do that they were doing beforehand. And there shouldn't be this place for compromise. You should be looking for that 100%. So you have to have a plan. Nobody plays sport to lose. Nobody plays to come second. They all want to win. So if you say to a guy playing sport, I can probably get you to 70% and you'll be grand, that's just not good enough. So sometimes you have to change your plan, you have to adapt a little bit, but there has to be a plan and you have to have an outcome. So things we know. This is a guy called John Colville, and 30 years ago he told us that tendons heal better if you put load across them, and tendons heal better if they move. Right? He was a surgeon in Belfast. There was loads of trauma. He had loads and loads of stuff to work with, and that has been universally accepted in terms of tendon healing since. There is nothing to contravene that as a concept. So loading is good, movement is good. Everything comes down to wound healing. And this is a guy called Sean O'Neill who works in James's. He's a vascular surgeon. And Sean, about 10 years ago, told me this profound statement. He said, you know, all of your wounds are venous. And it makes perfect sense. That your heart has never been able to pump fluid uphill. The driver for uphill fluid pumping is your calf. It's a mechanical pump. And it doesn't work if you're in a boot. It doesn't work if you're not fully weight bearing. It doesn't work if your calf isn't moving. So if you can control the swelling, the wound will heal. This isn't, you know, there's nothing unusual about it. So if you look at this foot, the foot on the left-hand side or my right is purple, not because there isn't blood flowing into it. It's purple because there isn't blood flowing out. It's swollen because there isn't blood flowing out. So everyone should have their swelling managed. And if you manage that, there's no reason why the wounds won't heal. So there was actually a video in that showing a thing called an Una boot, but it's a simple compression dressing. We put everyone in compression stockings or compression dressings from start to finish. So in terms of surgery, this is really simple. It's like putting a stitch in a sock. It is bad side down, full thickness flap. All you want to do is connect the two ends, but the recoil in this is on the top side, not on the bottom. So you have to get the top down, you have to free it out, release it, and tack a stitch into it. In all of them, we release what FHL fascia, and really that's to give space. It massively decreases wound problems. Probably gives it a bit of blood flow as well, but it's really simple. You grab the top end, and I don't know, will this play or not, but it does. The most important thing is the top end has to move. You know, if you look at these, they get stuck down really quickly. There's no point in sticking a stitch in a tendon and it not being mobile. I use fiber wire as a stitch. It's non-dissolvable. It's fairly strong. You can certainly move it early. It's strong enough to do that. It's not strong enough to load body weight, but it's strong enough to move. It's a very simple stitch and it's reinforced with Vicryl. Again, nothing complicated about this. Closure is fairly important. You want to close this in layers. You want to get a good approximation, no tension, and then just wrap it up. So, sorry, this is the video. So this is a thing called Nuna boot, and it's a simple 4-layer compression dressing. The vascular people have used it for donkey's years for varicose veins, ulcers. It is a brilliant way of controlling swelling. It gets really tight if the foot swells, and that is never, like, a dressing doesn't get tighter. It can't get tighter. So if someone has a foot that suddenly feels really tight, it's because it's swollen. You put it back up again, and that will sort out the swelling. So everyone weight bears from day one. There has never been an indication to not weight bear. We put a series of little heel lifts in the back of the boot. I generally put 6 3mm heel lifts. It's more than enough. If they're very, very tight, 3 mil heel lifts. If they're very tight or if they're late in terms of coming to theatre, I might put 8 in. But the object is try to get them out reasonably quickly. You want the heel dropping down to the ground more or less as quickly as you can. They're booted, they're fully weight bearing, they're wrapped. I don't routinely anticoagulate. If someone has started it already, I keep them going. If they have a positive history, I keep them going. But the mechanical stuff is probably far more important in terms of clotting. I know in the UK everyone gets anticoagulated, but they then don't put compression stockings on. They don't work. They don't do the mechanical side of it. They just do the chemical side of it. There is no real problem with doing both. Everyone fully weight bears. Boot is on for 6 weeks. The lifts come out early. Really what you're interested in these in terms of rehab is to get the knee bending over the foot early, and you can do that probably after 2 weeks once the wound is dry. If you simply have a controlled standing position and get the knee bending, it will work much better if you get movement early. The biggest problem we see with these people coming out of a boot at 6 weeks is they can't bend their knee over the foot. And there's no problem doing simple non-loaded seated calf raises again early. It's good for a little bit of load coming through it. You should be coming out of a boot between 6 to 12 weeks. You should be able to drive early. You should be able to get up on a bike week 7, not really with any great amount of resistance, but looking for flexibility. This thing won't work if you don't get early flexibility in it. If the whole thing locks down, you're getting nowhere with your physio. You should be able to do a double heel raise, no problem, by 12 weeks. You should be able to get out of a saddle of a bike by 12 weeks. You should be normal walking up a stairs by 12 weeks. And really where we want to see people is if they're not hitting markers, we want to know why, and we want to know what can you do to intervene in these early. 16 weeks, you should have no problem doing a single heel raise. Walking speed should be normal. You should be normal going down the stairs. 20 weeks, you should be running. And really 26, 28 weeks, we target a return to sport. Now, a lot of people will say, oh, it's probably going to be 8 weeks or 8 months or 9 months. I think you should push your targets really hard and try and push someone to get back at 26 or 28 weeks. And then if it runs a little bit, it's not the end of the world. But if you give someone loads and loads of space, they'll just take it, and suddenly they're 9 months, they're 10 months, they're weak, and they don't get back any quicker because you've given them loads of time. They've just taken longer. So half the country do not operate on Achilles tendons. Their standard management is put them in a boot, put a whole load of heel lifts in, or point the toes downwards, and you'll be grand. But it really depends on how you sell it. If they go into casualty and say, well, you can have an operation or no operation, and if you have an operation, you might get a massive wound problem, and that'll be a disaster. Or you can have no operation and you'll be grand. But you won't be grand. Everyone gets a bit of soleus atrophy. Everyone loses a bit of power. If you look at re-rupture rates, they'll say, oh, re-rupture rate is the same, operated or not. But the one that they quote in terms of the re-rupture rate operated not being the same has an operative re-rupture rate of 5%. That's just outrageously bad. Your operative re-rupture rate should be way under 1%. So you're not comparing apples and oranges. Generally, you will get more proper power output. You can drive a car with no Achilles tendon. You can walk with no Achilles tendon. You can't hop, skip, jump, or run, and you certainly can't run fast. So the better you get this functioning, the better you're going to run in terms of running speed and recruitment. It just works better. It makes absolutely no sense to not do it. So if I was Achilles and I was dying on the battlefield and someone came out and said, don't worry, Achilles, you'll be grand, I'd be trying to get out of there. So I think that's me.
Thank you very much, Johnny. That's fantastic. And so what we'll do is I'm just going to we'll go through a couple of little questions, a little bit of discussion before we bring it. We'll do the paper. I'm going to bring James back first of all because I asked him a question just at the start before your presentation regarding on baseline testing for professional athletes with respect to strength testing across the Achilles complex and having those baseline tests at the start of the season and something to work back your rehab. Is that something that you do in professional basketball, James?
It's a political answer, really. So yes, it would be something we would ideally do. It's not something we always do. It's more politics than anything. The guys won't necessarily be profiled at the beginning of the season, but we will track their load outputs either through seated calf, standing calf, different measures throughout the season. And the reason why it's a bit political is because in the NBA, there's something called the collective bargaining agreement, which means that once the season finishes, as a franchise, as an organization, you're not really allowed to contact the player and or work with them in the off season. And they have a 3-week pre-season before you're into 82 games. And so to try and test and make sure they're ready for the season in 3 weeks has a certain risk associated with it. So we tend to try and drip feed the test through the season as we go, because we're not always 100% confident of the level the athlete is coming back from after having a couple of months off. And there's a bit of re-establishing load onto the system to get them ready for those 82 games of the season. But certainly it would be something that we would do. So we would strength test them, we would jump test them, we would movement test them, and we would look at some kind of metabolic or endurance marker as well. And they'd be our main kind of criteria we'd look at.
Okay, and would you see in a squad in a professional year, how many Achilles tendon ruptures would you see? I mean, is this something that happens very occasionally in the professional setup in basketball, or is it more common, obviously, in basketball than you'd see in other sports? Or
I mean, I don't necessarily know the figures off the top of my head. I don't know that there is, again, because of the CBA, there's not a huge amount of research that's done within the NBA. There's a fair bit done within NCAA, so collegiate level, university level, but there isn't a huge amount done within the NBA. Certainly, anecdotally, if you speak to a lot of the teams, and we had Kevin Durant playing for us, who famously ruptured his Achilles tendon, and we had another player with us last year who did it. In our team, we see very, very little Achilles tendon problems and very little tendon problems in general. But I would argue our tendon loading prophylactic program to reduce the risk of tendon injuries is very good. And if I speak to a lot of other teams, they have a lot more tendon problems than we do. That doesn't mean we don't have problems. We just have more muscle injuries, hamstring related, ankle sprain related injuries than we do tendon problems. And I think that's probably just biases our particular strengths and weaknesses around the way in which we manage those athletes.
Thanks very much, yes. And Johnny, regarding the surgical management of a rupture, I mean, timing from surgery must be like most tendons, timing, especially proximal avulsions around the hip, where I would deal with timing is very important. How important is actually getting in to do the repair at an early stage as opposed to a misdiagnosis or a delayed diagnosis or a late failure of conservative management and going in then weeks or sometimes months later?
Yeah, it doesn't make as much difference as you think. You need a little bit more height and you need to drop them down a bit slower. But there's loads of stuff written in the books about, you have to do a tendon transfer, have to do an FHL transfer if it's after 6 weeks. It's complete rubbish. I haven't done an FHL transfer in 5 years.
Okay.
You can always, and even turn downs and things, if you're a bit more patient. Now, your easiest way of figuring it out is if you're actually looking at the tendon and you look at the undersurface of it. If there's muscle there and the thing is mobile, it's rehabilitatable. If you're someone a year down the line and it's a completely misdiagnosis, that's all turned to fat and scar tissue. It has no pliability, it has no ability to contract. That's not going to really serve a great function for transferring any sort of load. But 3 months means nothing. I mean, if you come in to me and say, I'm going on holidays next week, what will I do? I'll say, go on holidays and I'll fix you when you come back.
Okay.
Okay.
And regarding the rehab and return to sport, it still doesn't make that much difference. It's not a longer rehab, a slower rehab.
It's obviously going to slow them up a little bit, but it's not as massively time critical. The guys who you're talking about won't have a misdiagnosis. Yeah. They're picked from day one. You can't miss it. Really, you're talking about someone who plays a bit of football, and the classic thing is they go into a casualty department and someone says, well, I don't know, is it gone or not gone? Maybe we'll send you for a scan. And they wait 4 weeks for a scan. Should they told the man when he walked in the door it was snapped?
Yes, of course.
So it's just a failure to listen to a patient, and they're quite swollen, they're a bit sore, but once the swelling goes down, the patient thinks, maybe I'm not that bad, I'm fine. Look, I can walk. And you have 4 other plantar flexors. Someone lies them on the couch and they can plantar flex. They say they're grand, but they only twig then when the swelling goes down and they can't push.
And are there warning signs? I mean, if your hamstring is going to go, or you've got a rectus femoris injury proximate, quite often, players can feel a little bit of tension in the tendon and maybe a number of weeks beforehand. Some of the warning signs. Does that happen with the Achilles tendon in the same way as happens with more proximal muscle tendon groups?
Not really. I mean,
No.
a percentage of them have a preceding tendinopathy, but there's no correlation, over the bigger term. If you look at all the tendinopathies, they don't have an increased rupture.
Okay. And James, yourself, do you see when you get a player who is complaining of maybe recurrent bouts of inflammation or tendinopathy, and is there a worry of in the professional sports? Do you ever see that turning into something more serious, an acute event, or is it generally something that just remains chronic?
No, I don't think it does ever turn into anything now. I think the fact that they've got tendinopathy with pain, they normally have some kind of impairment in function, so they become self-limiting anyway. And because they're self-limiting, that really high-end reactive force is not going through the tendon. They develop different movement strategies, different compensations, different ways of functioning. So we don't tend to see those ones that transfer from tendinopathic symptomatic tendons into those full ruptures. I think the full ruptures are usually largely unpredictable in nature within that elite sport world, and it's usually some kind of innocuous mechanism. The classic one was if you were watching the NFL at the end of the season, the guy that was just bouncing on the sideline, getting ready to go in and went to accelerate to go into the game, was spontaneously ruptured as he went to push off the leg, and you could see that clearly happening.
Okay, so what we're going to just going to bring in the paper that we've selected today. Was an example of just a combined a injection and debridement of an Achilles tendinopathy, and it was something that caught our eye, and regarding just a topic for discussion as well. So I'm going to ask David just to come in to just do a summary of the paper, and we've asked a number of the delegates also to do a small survey for us. And so we're just going to present in 5 minutes just the results of the summary and the presentation. Thanks very much, David. And then we'll have a discussion just briefly afterwards.
So the paper we kind of chose to kind of review was published in the Journal of Clinical Medicine. So it focused on the return to sport and functional outcomes after autologous platelets-rich fibrin matrix and debridement in mid-portion Achilles tendinopathy. And it was a case series with 24-month follow-up. So the aim of this study was to examine the long-term, which was 24 months in this case, pain, functional outcomes, and scores of a cohort of patients with Achilles tendinopathy who received tendon debridement and autologous PRFM augmentation. And the hypothesis of this study then was that PRFM would ensure an early return to sports as well as a satisfactory functional outcome. So this was a case series. It was a single center, single surgeon case series. The inclusion criteria was cases operated on between August 2016 to October 2020 who had Achilles tendon debridement and autologous PRFM augmentation, greater than 18 years of age, and they had to have a mid-portion Achilles tendinopathy pain confirmed by MRI. They excluded then patients who were greater than 40 years of age, elite athletes, and anyone with chronic rupture or acute trauma greater than 10 days previously. The methods of assessment, so preoperatively and postoperatively, the functional data was obtained retrospectively. What they focused on then was an evaluation of pain on activities of daily living, including assessed using the VISA-A and the AOF-AS scores, and these were assessed preoperatively 6 months and 24 months. They also looked at the Blazina scores, ankle range of movement, and patient satisfaction, which was recorded at 24 months. Statistical analysis is quite short in reporting this paper, so they used SPSS and they used just a single student's t-test for paired samples as their method of analysis. There was 32 cases included after considering the inclusion and exclusion criteria, approximately about 50-50 split between males and females, and the average age was 28.7 years of age. In terms of return to sports, all patients returned to sport at the same level or higher after 25 days, and the patients continued to play sports throughout the follow-up period, and all patients returned to work after 16 days. In terms of ankle range of movement and satisfaction, so these were they presented the data in terms of the mean change in mean difference in dorsiflexion between the injured and uninjured ankle, and they presented these at 1 month, 6 months, 12 months, and 24 months. And then in terms of satisfaction, there was a very big satisfaction, 100% satisfaction. So this was patients reporting their satisfaction in terms of being very satisfied or just satisfied. They looked at the Visa A scores then, and they found that there was a significant increase from pre-operative to 6 months post-operative, and they substantiated this increase in terms of statistical analysis by a p-value less than 0.01. They also presented the findings or the results at 24 months, but didn't provide any statistical analysis in terms at this time point. So they did this for AOFAS score and the Visa A. The Bazina scores as well, they pre-operatively there was 27 and 5 cases identifying or presenting with pain that was affecting their activities of daily living. And then post-operatively, the proportion or the distribution of these scores for this outcome measure was all focused on less pain. The limitations that were reported by the authors included there was a small cohort with a short follow-up period. There was no measure of the mechanical properties of the heel tendon performed, and it was a non-randomized, non-controlled design. So in conclusion, based on the results, the authors concluded that the surgical management of symptomatic mid-portion Achilles tendinopathy with debridement and autologous PRFM application ensured a fast return to sports. There was significantly increased outcome scores at 6 months, and this provided excellent clinical outcomes at 24 months. So we asked people to fill out the evaluation form, and the general consensus, I suppose, was that there was a sufficient overview provided in the background in terms of introducing this topic. 80% of people felt that the rationale was clearly stated and the objectives were clearly stated. The methods, there was about 40% across the board really felt that the population was appropriate and the inclusion and exclusion criteria was appropriate. So this was quite a small percentage in the grand scheme of things. And 40% felt that the methodology was sufficient, which means 60% felt that the methodology was insufficient to allow reproducibility of this study. There was a 0% of people felt that the statistical methodology was appropriate. In terms of results, only 20% of our delegates who filled out this form felt that the findings were novel. 20% similarly felt that the results allowed for interpretation of clinical importance, and then 100% felt that the data was presented in a way that's easy to understand. I think the majority of people filling out this form felt that the limitations had been highlighted. So 60% felt that all the limitations had been highlighted, but 80% of delegates who filled out this form after reading this paper felt that the limitations did confound the robustness of this study. And the conclusion, the general consensus was that 6% of delegates filling out this form after reading the paper felt that the conclusions could be supported by the methodology, but 20% felt that the conclusions would influence their practice going forward. So quite a small percentage, I suppose, in the grand scheme of things. The overall rating then of this paper was 2.4 out of 5, considering the ratings and various background methods, results, limitations, and conclusion.
Thanks very much, David. So back to just James and Johnny, just talking about the paper, we sort of selected this paper for a few things. First of all, it's an open access paper, and therefore, if you pay the journal, you get your paper published if it's reasonable. But we've got to be very careful, I think, sometimes in the quality of the papers that we're reading on open access. And so the one thing I wanted, as a non-foot and ankle surgeon or clinician, is the debridement of a chronic tendinopathy or the use of PRP. Is it a mainstream treatment, Johnny? I mean, is that something that is done for chronic tendinopathy, debriding this type of sort of a scarred area, or to try and promote more vascularization and bringing PRP augmentation into that? Is that something that you come across, something that you do, or something that you're aware of? You're muted there. Sorry, Johnny.
All right. The guys in sports med use PRP the whole time, but debriding it, no, I mean, I just don't really believe any of it. I don't honestly think you can get back to sport 4 weeks later with no symptoms if you had something that really needed an operation. I mean, that's not the recovery time of a tendon. It's just not the way it works. And if you get a paper where he's talking about sports people and there's a 57% smoking rate, again, it's not, you're probably talking about an operation that just didn't need to be done, and the person would have got better anyway if you just managed it medically. That'd be my take on it.
Okay.
James might have a different notion of it, but
James, is it something? Is it?
That was the biggest take home for me was the 25 days turnaround. Is you're not changing the collagen matrix, so you're not improving the structural integrity of the tendon. All you've done is somehow manipulated the pain response in some sort of manner, and like their inclusion criteria on the physical metric side of things, whether that's an intrinsic mechanical measure or an extrinsic mechanical measure, was not clearly depicted, as in failed eccentric strength program. Their conservative rehabilitation process off the back of the intervention wasn't clearly stated. So methodologically, it was a very poor paper, I would argue, in terms of really understanding the methodology of what they did, and how you could take away your take-home messages from that, because I don't think it's clear exactly what pathology you're dealing with in the first instance to have a starting point to know where to go from on that.
Yeah, I think from the paper, from the methodology point of view, from my perspective, being just a reader as opposed to somebody who knows anything about Achilles tendinopathy, the group that they wanted, I started one of the things the group is they wanted to include, to say the most common group is in 40 to 55-year-olds, and that's the group they actually excluded from the research. They didn't include any elite athletes. They didn't talk to us about the sports frequency or the intensity levels. There was no preoperative range of movement assessment. It was only compared to the contractor side post-op. It was a retrospective, non-controlled trial. They excluded chronic tendinopathy, which to me is the very case you'd be probably trying to do this on if it wasn't settling down over a lot of time, and only 38% follow-up with no power analysis. And so to me, it was really a very, very poor methodology paper, and we wanted to highlight that as well, as because a lot of people out there will read these papers and thinking that this is a very successful treatment, and I think the conclusions certainly in this case are not supported by the results or the methods. Just I have a question coming through there. Questions for James. What conversation are you having with your athletes in relation to return to play, in terms of time frames, markers to hit at certain stages, and would you have athletes back sooner than Johnny's aforementioned 20 weeks? Would these time frames change between sports, say that Newcastle player to the Nets? Thank you.
Wow, there's a lot in that. Yeah, look, I think the timeline has got to be individually based and based around what your outcome and what you're trying to achieve. So there's a difference between, let's say, Callum Wilson, who was the player there. We've also just been dealing with a guy called Joe Willock, who's up at Newcastle as well with the same issue, and they've given me permission to talk about their cases. But then we managed and designed a lot of the rehab for Katarina Johnson-Thompson going to the Olympics when she ruptured her Achilles and had it surgically repaired. And so very, very different, because the outcome of an elite potential gold medalist, heptathlete, Olympic champion versus a footballer is very different. So you've got to shift your timelines according to the individual and according to the surgery and according to what the surgeon finds during the operation, because there may be some nuances, as I'm sure you'd agree, Patrick, between your different sort of surgical repairs with muscle injuries and tendon injuries that you're dealing with. I think the big difference with basketball over any other sport is we know it's a hard court surface. Hard court surface increase the risk of ankle overload injuries versus grass or track and field. And we know with basketball, there's a lot more deceleration mechanics and a much more anterior chain deceleration. And deceleration, that energy storage as an energy attenuation is much more within the tendon to store that negative energy, as opposed to the mechanical forces where you're producing the force to go through. So I think those loads tend to go up much higher within basketball, and so therefore you may well have a slightly slower progression to get the tendon ready and make sure everything else is operating well enough so the tendon can transfer that energy. My final point on all this would be, I think it's always important to note that the tendon is the attenuator of force, and yes, it amplifies the force of the muscle, something like 4 to 5-fold of the muscular force that's been utilized, but at the same point in time, it's there to augment the function of the muscle and the joint in movement. And so you've got to make sure the joint is working well, all the joints above and below are working well, that the muscle components are working well, to then be able to utilize the tendon efficiently. And I think sometimes we can focus too much on the tendon because that's the source of symptoms, certainly in tendinopathy, and you sometimes don't always get all the other contributing elements to it, regardless of and the nuances of the different pathologies that may be involved there.
Thanks very much, James. And just Johnny, just the last question, just for a lot of the physiotherapists and things who are out here regarding managing chronic tendinopathy, and is there a role for surgery in the management of chronic tendinopathy in athletes? If the conservative treatment is not getting on top of the symptoms, I mean, is there a role for surgery up in sports surgery clinic, for example, and under your sort of guys?
Yeah, but all we really do is decompress them. So
Okay.
I showed an FHL fasciotomy there, but if you take out plantaris, you don't really debride the tendon. If you actually debride the tendon, there's a big rupture risk. But you just take the fatty tissue off the tendon. But the most important thing is split FHL, and you have to have. It's basically giving space. It's like taking a computer that's jammed and turning it off and turning it back on again. You're giving it blood flow. You're giving it space to expand when it loads. Most of the symptoms are constrictive. You have a tendon that's getting fat in response to loading. It's meant to get fat in response to loading. That's a normal response. You know, it's getting fatter to stop it snapping. That's nature's perception of what it's doing. But it has no space to do it. So if you just give it the space, a lot of the symptoms will settle. But the tendon then needs to reset, and your rehab needs to start after that. And a lot of them, they'll find the whole rehab process much easier because it doesn't hurt as much. Okay. But you're not making the tendon stronger. You're literally clicking a reset button.
Okay.
There are loads of things. I mean, I wouldn't touch a tendon unless they've had their bloods checked for gout, unless they've had a night splint, unless they've had a heel lift. I'm not a big fan of eccentrics. I think you shouldn't overload a loaded tendon if it's failing to respond to load. Why would you just stuff more at it? But James is laughing because he obviously doesn't agree. But you know, I don't. You know, it's like a blister in skin. It's just overloaded. It just needs a chance to settle.
I'm laughing, Johnny, because I do agree.
Oh, good. I'm glad. I think far too many people think it's all eccentrics, and it's not.
No, not at all.
You can't stretch a tendon. It doesn't stretch. That's why it fails.
Yeah.
Okay,
Agreed.
guys, listen, unfortunately, I'm going to have to, our time is up. So I want to say thank you to Johnny McKenna, consultant from Sports Surgery Clinic in St. James's, for your time, and for James all the way from New York, and good luck with the game tonight. Hope we're all now Brooklyn Nets fans. Okay. And
don't know about that, but thank you.
And listen, all the very best, and hopefully we'll get a chance to talk again and get another webinar or another conference sometime in the future. Listen, thank you again, both of you. Absolutely fantastic.
Perfect.
Appreciate your time. Thank you, guys.